To get into blood disorders, let's talk about something called a CBC. So, if you like to watch medical shows, you might think of a scene where they're rushing someone into the emergency room and then the doctor yells out, "Get me a CBC, stat." That CBC is what is called a complete blood count. So, it looks at three of the four main components in the blood. It looks at the numbers of them, how many of one type there are in relation to the numbers of the others, and then also information on their appearance, like the appearance of the cells. And that CBC is essential in determining anemia and which type a person has. So what really is anemia? It's this reduction in the oxygen carrying capacity of our blood. And often it's related to a decrease in the number of circulating red blood cells. So when we say anemia, that's what we're talking about. But it can come as a result of a few different things. It can come as a result of a nutritional deficiency, where someone's lacking the essential components to form red blood cells. Or it could even come from a suppression of the bone marrow stem cells. So when we're talking about anemia, there are a few things that all the different types have in common in the way that they manifest themselves in the oral cavity. So the skin will be much paler, the mucosa as well, angular cheilitis, which we've seen in earlier chapters in this book. There can also be, while there can be pallor, there can also be erythema and atrophy of the oral mucosa. And then the tongue, we'll see loss of filiform and fungiform papillae. So here are a look at a few of the different disorders of red blood cells and hemoglobin, and we'll get into the first several right here. So when we're talking about iron deficiency anemia, we're talking about when the body is lacking sufficient iron to develop red blood cells. So that could come from a few different reasons. It could be that a person just didn't take in enough iron, dietary lack of iron, or it could be that they're losing blood, maybe from heavy menstrual cycle, or they've got some sort of internal bleeding. Maybe they're taking in iron, but they have poor iron absorption. And then maybe there's a change in that individual's physiological demand or their need for iron. Maybe it's a situation like when a person is pregnant. So some of the symptoms of iron deficiency anemia are pretty nonspecific weakness and fatigue. Those are the things that we think about, we expect. There's also shortness of breath, cardiac palpitations, and some of the things that we've talked about already. Some of these will specifically show up in a very particular and rare form of longstanding iron deficiency anemia, and that one's found in Northern European and Scandinavian women. It's called Plummer-Vinson syndrome, and then those are marked there with the letters PV. So here we have figure 9.6 from our book, and we can see some of those effects manifested here. Here we see angular cheilitis highlighted in the corners, and then we see the loss of the filiform papilla. And then, is it possible maybe we're also seeing some oral candida? Okay, so how is it diagnosed and how is it treated? Well, we use laboratory tests, and so we'll look at those, and then what we end up seeing is a reduced serum iron level. We'll see low hemoglobin, and remember, hemoglobin is the protein responsible for transporting oxygen in the blood. There will also be a reduced hematocrit, and the hematocrit is a measure of the proportion of the red blood cells in your blood, so that's part of the CBC. So we don't want that lower iron level. That iron is needed for hemoglobin synthesis, and so we can find a situation developing where a person can have a microcytic form of anemia, meaning that the red blood cells are smaller than normal, or it can be hypochromic, where the red blood cells are lighter in color, meaning they're less color, hypochromic. And so for treatment, well, we'll replace the iron. There are dietary supplements. And then what's interesting is that the oral lesions, whatever we're seeing in the mouth in that last image, those will resolve when the deficiency is corrected. So that's great. So next we're going to talk about pernicious anemia. And pernicious anemia is something that's caused by a deficiency in intrinsic factor. But what's that? So, intrinsic factor is something that is necessary for the absorption of vitamin B12, and it is secreted by the parietal cells that are there in the stomach. The thought is that it's usually an autoimmune disease or disorder, that causes that the majority of the time. It could also be caused by a removal of the stomach. So remember, it's the parietal cells in the stomach that excrete it. So when someone loses their stomach, they are not able to make intrinsic factor. Or it could be gastric cancer or gastritis, that inflammation there. So in the end, that results in an inability to absorb the vitamin B12, but we need B12 because it's necessary for DNA synthesis. And since it's so necessary for that, then we have these rapidly dividing cells, which are depending on this DNA synthesis. So that's going to affect those cells like the bone marrow cells, which means that it's going to affect their ability to produce red blood cells for us. No matter the cause of the B12 deficiency, the deficiency causes the same systemic and oral features, which you can see below. Among them, of course, are weakness, pallor, and fatigue, just topping off the list. So what does this look like in the mouth? Well, here we see angular cheilitis, which you can see in the top image. We can also see pale mucosa, although sometimes it can go the other way and be really painful and red and also display some atrophy of the tissues. Another issue is ulceration of the mucosa, which then follows that atrophy. And more than half of the people with this vitamin B-related anemia show a loss of papilla on the dorsum of the tongue, and or as we talked about last week in orofacial pain, they can also experience some burning tongue. So now when it comes to the diagnosis and the treatment of pernicious anemia, we get into laboratory tests. So the laboratory tests involve looking at the serum levels. We're looking for low serum B12 levels, of course, and then gastric achlorhydria. So there's a lack of hydrochloric acid. People also will show megaloblastic anemia, which means that basically they have these abnormally large red blood cells and which show nuclei in them because of these issues that they're having in the bone marrow stem cells. They'll also show immature neutrophils and platelets. Then there's this thing called the Schilling test, which is used to detect the inability to absorb oral vitamin B12. And what's used most frequently is a check for the presence of serum antibodies directed against intrinsic factor. So how is this treated? Well, it's treated with monthly injections of B12. And then what's beautiful is that the oral mucosa will improve following adjusting for that issue. However, the papilla may not completely return. So now let's look at folic acid and vitamin B12 deficiency anemia. Similar, but a little bit different. So we know that folic acid and B12 are essential for DNA synthesis. And what happens is that there is a dietary deficiency, and that results in the anemia. So this can come from malnutrition. Maybe somebody is an alcoholic. Oftentimes that occurs in association with alcoholism. Other at-risk groups include vegetarians and vegans. And then once again, it can come in with an increase in metabolic requirements. For example, pregnancy. Somebody has additional need in pregnancy, which is why we see this included in all the prenatal vitamins. Something to note, though, for the vegetarians, while B12 is not generally found in plant foods, you can get it in fortified breakfast cereals. So those are readily available. And one reason for that is to help with unintended pregnancies where maybe someone's not preparing and they're not on prenatals, but this way they already have sufficient folic acid. So let's check out some of the oral manifestations. Again, because the issue is a lack of B12, you really can't tell the oral signs apart from pernicious anemia because it's the same issue regardless of the underlying reason why the person is not getting the B12 in. So again, you see angular cheilitis, the pallor, ulceration, and so forth. So the diagnosis for this, again, is based on laboratory tests. We've got serum assays of the folic acid and B12, checking that out. They'll also look for the presence of the megaloblastic anemia. And then this one is a little easier to treat. We can just go with dietary supplements. So now let's look at thalassemia. And in thalassemia, that's really the name for a group of inherited disorders of hemoglobin synthesis. So this represents an issue with the formation of the hemoglobin. And now remember, hemoglobin is the protein responsible for transporting oxygen in the blood. So thalassemia is actually a recessive condition. So there are some who end up being unaffected completely. There are some people who are carriers, and then there are those who actually display the condition. So there's, first of all, thalassemia minor. And in this form, someone inherits just one involved gene. So the expression is really minor or mildly symptomatic, and they can even be asymptomatic altogether. But then we have thalassemia major, and in this one, the individual inherits it from both of their parents. So what this shows up is as severe hemolytic anemia, and that means that basically it causes damage to the red blood cell membranes and then therefore death of the red blood cells. So what are the clinical features? So the clinical signs begin to show up in the first year of life. Because the person has defective hemoglobin, basically they have those fragile red blood cells. They're going to die pretty quickly as they're circulating throughout the body. And that can range, of course, from that mild to moderate hemolytic anemia. They'll end up with hypochromic anemia because of the lack of the proper red blood cells. And so physically we'll see yellow skin, pallor, fever, there'll be the weakness, malaise, all the things we expect, as well as an enlarged spleen and liver. And the face also has a particular characteristic feature. So we'll see prominent cheekbones, the nose. Look at how the nose is sort of depressed. And then the maxilla is sort of outward. It's exophytic. It's very prominent. And then in the teeth, we've got protrusion and flaring of the maxillary anterior teeth. And if you think back, it may be something that you've seen before, but just didn't know why. And so that's the case. That's thalassemia. On the radiographs, they show what we call a salt and pepper pattern. So basically, some of the trabeculae on the radiographs are more prominent, and then others pretty much disappear. So it looks sort of like a spotting or a dotting, and that's why we call it salt and pepper. Also, on the dental x-rays, we'll expect to see a thinning lamina dura and some circular areas of radiolucency on the alveolar bone. And then here we're seeing an image of the radiograph. You can see this hair on end appearance. It almost looks as if there's spicules or spikes showing up, spicules of bone. So how is this treated? So thalassemia is typically treated by regular blood transfusions, but these are not without their complications. So one of those is hemochromatosis, and that is the deposition of excessive iron throughout the body. And it has a lot of side effects. And one of the issues, it can lead to heart failure. It also can cause early neurological disease, impotence, infertility, just the list goes on. And so what they do to treat that are administer iron chelating agents. And so chelating agents are basically factors that are able to bind the metal ions, and that causes them to drastically reduce their reactivity in the blood. And then the idea is that they can eventually enter the bloodstream and then be designed to excrete the iron through the urine or the feces. So they form these complexes, and then they bind that iron, form the complexes, and then the person excretes them. And so the prognosis for people with thalassemia is really beginning to improve with these new advances. And lastly, we're going to go into sickle cell anemia. I'm going to play a video for you which goes into it. Now, this one is another inherited disorder. This one primarily affects those of African, Mediterranean, or Asian ancestry. And then you can reference the slides 92 to 96 or page 282 to 283 in your book to follow along. The main thing I'd like to point out is the oral effect on the bone. So similarly, you'll see the loss of trabeculation that results in irregular marrow spaces. And just like in thalassemia, there's this hair on end pattern in the skull. But right now, I'll go ahead and let you watch that video.